Welcome. This presentation will cover the essential signs, symptoms, and management of acute myocardial infarction, commonly known as a heart attack. Understanding these critical details is vital for any healthcare provider, as rapid and correct intervention can save a life. We will begin by exploring the clinical presentation of an AMI, followed by a step-by-step guide to emergency management. Acute myocardial infarction, or ANI, typically presents with sudden, severe, and persistent chest pain. Unlike angina, this pain is prolonged, lasting more than 15 minutes if left unmanaged, and can persist for 30 minutes to several hours. Patients often describe it not as a sharp pain, but as a deep, crushing ache or intense pressure, primarily located in the substernal area of the chest. A crucial diagnostic indicator is that this pain is not relieved by rest or the administration of nitroglycerin.
While the pain is centered in the chest, it radiates following the pattern similar to angina.
It can travel to the left shoulder, down the left arm to the fingers, and into the left side of the neck and jaw. In some cases, the pain may radiate to the right shoulder or even to the epigastrium, mimicking indigestion. Beyond chest pain, a patient experiencing an AMI will exhibit a range of associated symptoms that paint a clear picture of systemic distress. A profound sense of apprehension and fear is common, often described as a feeling of impending doom. The patient may appear weak and break out in a cold, clammy sweat. Dyspnea or shortness of breath is a frequent complaint, sometimes accompanied by coughing or wheezing. Gastrointestinal symptoms are also prevalent, including nausea, vomiting, and a sensation of abdominal bloating. Many patients will feel lightheaded or dizzy. It's important to recognize this entire constellation of symptoms, as they collectively point towards a major cardiac event. When you physically assess a patient with a suspected AMI, you will observe several key signs. Their skin may appear pale, a condition known as pallor, or even have a bluish tint, which is cyanosis, especially around the lips and nail beds. The skin often feels cold and moist to the touch. When checking the pulse, you might find it to be weak. Tachycardia, or a rapid heart rate, is the most common finding. However, it's important to note that bradycardia, a slow heart rate, can also occur, though less frequently. Cardiac dysrhythmias are a significant risk during an AMI and must be monitored for it. Blood pressure is often low, but it can sometimes be within the normal range, which can be misleading. Respirations are typically shallow and rapid. A critical point to remember is that this severe chest pain can be the very first indication of heart disease. The patient may have no prior history of angina or chest pain. In the event of a suspected acute myocardial infarction, your immediate actions are critical. The very first and most important step is to call 911. Do not delay. This single action initiates the chain of survival and brings advanced medical care to the patient as quickly as possible. Every minute counts in preserving heart muscle, and activating the emergency medical system is the non-negotiable first priority. While waiting for emergency services to arrive, your management depends on the patient's level of consciousness. If the patient is conscious, your primary goal is to keep them calm and reduce the workload on their heart. Position them in a comfortable sitting up or semi-sitting up position. This helps ease breathing and reduces venous return to the heart. Immediately begin your assessment following the CAB protocol. Check for circulation, including pulse and blood pressure. Ensure the airway is clear and assess breathing and responsiveness. Administer oxygen to improve blood oxygen saturation. You can also give nitroglycerin, but remember, in an ME, it likely will not relieve the pain. A single dose of 325 milligrams of aspirin should be given. Have the patient chew it to speed absorption. If available, a mixture of 30% nitrous oxide can be used for its analgesic and anxiolytic effects. It is absolutely critical to remember this warning. Do not administer epinephrine. If you find the patient is unconscious, the situation has escalated to a cardiac arrest. You must act immediately. Treat an unconscious, non-breathing patient as a cardiac arrest victim and begin CPR without delay. The priority is to maintain circulation to the brain and other vital organs. Start with high-quality chest compressions, pushing hard and fast in the center of the chest. Use the head tilt chin lift maneuver to open the airway and provide rescue breaths with supplemental oxygen. If an automated external defibrillator or AED is available, use it immediately. Attach the pads to the patient's bare chest as shown on the device and follow the voice prompts. The AED will analyze the heart's rhythm and deliver a shock if a shockable rhythm like ventricular fibrillation is detected. Continue CPR until the emergency medical team arrives and takes over. In summary, the key identifiers of an acute myocardial infarction are prolonged severe chest pain that is not relieved by rest or nitroglycerin, accompanied by systemic symptoms like sweating, weakness, and shortness of breath. The immediate and most crucial action is to call 911. Subsequent management depends on the patient's consciousness, involving either supportive care and medication for a conscious patient or immediate CPR and defibrillation for an unconscious one. Early recognition and a rapid, decisive emergency response are absolutely critical to improving outcomes and saving lives. Thank you for your attention. Be sure to review these protocols regularly to stay prepared.